So I got a call yesterday from someone who I really respect in the Medicare industry asking me if I had seen a post that was referencing an article online about the 340B program. I hadn't. He sent it to me, and I would like to run you guys through this because it's very uncomfortable to me. So currently there's a federal healthcare program called 340B that was designed to help low-income patients and communities. And the program started with really good intentions. The hard part to this is, though, some of the things that are happening behind the scenes with the 340B program are morally iffy from the downstream effects of it. So let's unpack that today. This is probably a 6 or 7 minute Medicare Minute and dive right into it. All right, so let's get into the genesis of this program and we'll go from there. So the 340B pricing program was created in 1992. The idea behind it was easy or simple, right? The goal was for hospitals and clinics that are serving vulnerable populations, they would be able to buy outpatient drugs at a steep discount compared to someone who didn't have access to this non-profitability. Now, the reason behind it is if providers are paying less for drugs, that means they can stretch their resources for underserved communities further and treat those more undeserved patients. On paper, when you're reading this, I mean, it's morally defensible. It's a good goal to help people in the United States here who are underprivileged, right? If you can get lower cost drugs, that means more access to those prescriptions. I don't think anyone can argue against that principle. But here's where the system gets complicated. Hospitals in this 340B program can purchase outpatient drugs at a steep discounted price, but they can still bill the insurers or Medicare or patients at a normal reimbursement rate. They can keep the difference. Now, that spread can be extremely large for certain specialty drugs. In fact, I might do another Medicare Minute on one unique insight that showed one drug, they were billing 10,000% higher than what they had to pay. So think about this incentive then. If you attach a clinic to your nonprofit hospital network, that means it allows you to buy drugs cheaper than if you hadn't attached it. So every acquisition then becomes a financial attractive incentive for doing the same services with the same doctors, the same patients, the same drugs. But now the ownership has changed, so the economics behind all of this has changed. And those organizations respond to incentives. They always do. It's across the country. Hospital systems you're seeing them begin to acquire oncology practices and dialysis clinics and infusion centers and outpatient specialty clinics and all kind of physician groups. You're seeing this from private equity, from venture capitalists all over the nation, because each additional facility connected to a qualifying hospital potentially then expands the access to that discounted drug purchasing structure. And it's not corrupt to do this. It's logical. It makes sense because the system is feeding it that way. So if you've got a system where the rules are rewarding expansion, then guess what's going to happen? People are going to begin expanding. But this is where the moral tension on, at least in my heart, would begin. Most of these large hospital systems operating in this space are nonprofit entities, right? And nonprofit entities often receive tax exemptions. Specifically, the article the man sent me says they receive property tax exemptions. So let's picture this in real terms. You've got a privately owned medical clinic that exists in your town. And the goal for 340B is that it would serve the underprivileged or underserved community. It pays those property taxes. Those taxes help to fund local schools, fire departments, police, libraries, infrastructure, emergency services. Then that clinic gets acquired by a nonprofit hospital system that is in the 340B system or that can get the discounted drugs. So we're talking about the same clinic, same building, same doctors, same services they've been providing. But now that property may be tax exempt. So that building no longer contributes to the local tax base in an underserved area. And if you multiply that across dozens of clinics and entire specialty groups and networks or regional expansions that hospitals are bringing in, suddenly large portions of commercial healthcare property are disappearing from taxable rolls. The local governments don't suddenly need less schools or less police officers or less firefighters or less roads, right? They don't need to stop repairing all the damage on the freeway or on the interstate or on the county highway. So what happens then? The tax burden that these clinics and hospitals used to share with the community is shifting. And it often shifts on to the local homeowners, the residents, the small businesses, and the working families that are already in an underserved, underprivileged area. And here's the moral question that needs to be said. Is it ethically right for a program designed to help vulnerable patients to indirectly then increase financial pressure on those same local communities? That's a good question, and that's a fair thought to have. Now, if you add on to this modern healthcare investment into the mix, private equity and venture-backed healthcare platforms and hospital systems, they all understand how these incentive structures work. And I don't fault them for that. They should understand how the incentive structures work. But capital will naturally flow towards any kind of drug-intensive specialty if they can get these steep discounts, any kind of infusion-based care or acquisition-heavy expansion strategies that hospitals are looking to purchase. Inside the current system, financial leverage exists. Duh, everyone knows this. And that's not villainous that it exists, but it's incentively responding, right? Let me rephrase that. It's responding to this incentive, and I don't know how morally correct this is. Now, moral systems aren't judged by intentions. They're judged by the outcomes. And the 340B program absolutely helps and funds important care in many communities across the United States. So that part is real. But it's also true that large-scale, tax-exempt healthcare expansion can shift what was originally their financial burden onto these local residents. And when public policy is creating incentives, we have to be honest about both the benefit and now the unintended consequence that these people are going to experience. Healthcare policy doesn't just affect patients. They're not the only people who have to pay from it. It's going to affect everyone in the community. It's going to affect the local homeowners, local small business owners, the local economy, the investment behavior of hospitals and venture capitalist groups and private equity, and sometimes even the property tax bill that comes to your own mailbox. So healthcare and reform like this isn't an isolating event. It affects entire community infrastructure. And this is probably something that should be looked into.